Welcome to our online meeting. Today is Saturday, February 24th, 2024, and a big thanks to Miles Jacobs. Miles is the driving force behind these meetings. I've been kind of busy lately, and to be honest, if it weren't for Miles, we wouldn't be having these meetings, or at least as often as we do. Like I mentioned, I've been busy. I recently moved to Florida to work on what I believe are two projects that have the greatest promise for aging intervention in the near future. One is a Yamanaka OSK gene therapy project, and that is intended to reset the epigenome towards youth, also sometimes known as cellular reprogramming. And that one's a few years out. The other is a plasma-based therapy project, and I'll be talking more about that a little later. So we found the discussion about peptides would take a lot more time than we have available during these meetings. So we'll cover that at a special meeting with Dr. Bill Lawrence. Jason Mercurio has made outstanding advances in AI, and particularly using the advanced features of ChatGPT. And I understand Miles has arranged with Jason to talk about that a little later. Do we have that right, Jason?
Yes.
All right. We're really looking forward to it. So, Miles, do you have any comments or anything before we turn the floor over to Jason?
No. Thank you very much, Johnny. That's it. I don't have this. I don't have a presentation this time. Thank you. You can go ahead.
All right. Jason?
Thank you. I'll go ahead and share my screen. I put together a short presentation for us here. Can you see that all right, Johnny?
I can see it great. It is in design mode. All right, there you go.
Perfect. Awesome. Well, thanks everyone. Thanks, Johnny. Miles, appreciate it. Today we're going to go through AI for longevity, and I'll give a very brief overview on the current space of AI and what might be coming in the future, as well as how do we use these current tools to pursue longevity and eventually reverse human aging in our lifetimes. And you can find me, here's my websites and social media, and feel free to reach out anytime. So a little bit about me. Background is primarily more on the quantitative side. About a few years ago, I started looking into aging more in depth and came to the realization that it is a reversible process. And once I came to that realization, I decided that we all have sort of an obligation from a moral standpoint to pursue these tools and technologies in an accelerated way. So that's the core mission, to effectively reverse aging in all 78 plus organs in the microbiome, including the ECM as well. Whether we replace things or whether we do rejuvenation, doesn't really matter, as long as the increase in function and really the way we look changes. Those are the things that matter. That we can continue our mobility and whatnot. So what is aging? Aging is really the core driver of all age-related diseases, and it's really the one thing that drives everything else. So from a capital allocation standpoint, it really makes sense to target the underlying driver rather than targeting the end products, such as diabetes and Alzheimer's and so on. And this is our current probability space. As AI is sort of now coming into existence, the question really becomes, can we push this curve out to the right? You can see sort of an inflection point right around age 80, where the slope becomes very steep here. And on the left axis, we have probability of death. On the x-axis, we have age. And really the goal is to push this curve out. That would be increasing health span, alternatively flattening this curve. And that's really what it's about, and that's where AI comes in and is there to help us to do that. And really, what do we want to do with it? We want to drastically decrease our risk. And I made these characters, I call them the 4 horsemen of aging. So we have diabetes, heart disease, cancer, and Alzheimer's. And really, if you can dodge all 4 of these, then you're really doing a good job. Those, you may be able to become a centenarian. Those are the 4 main killers. There's others of aging, but those are the main 4. So starting into the AI talk, starting at the end almost of where is all this going? And really it's going towards superintelligence. And superintelligence is this entity that we'll one day have in the future that is so much smarter than a human that we really can't even comprehend what it could actually do. You can see here in this picture, the biological range of intelligence right here is actually very small. There's really not much difference between a human and say a chimpanzee or an ape, even though just with a small amount of more cognitive ability and more functional brain tissue, we have things like art and music and computer science. But at the end of the day, we're nowhere near what this future AI will be, and we can't really comprehend what it could do. And it's clear to me that if we had this system, this computer software to some degree, it could cure aging, it could reverse aging, and it could do much more than that, and it could do it with its eyes closed. So what are the current tools of today? These are going to be things that are really rather basic in the pre-AGI, human level AGI world, but really we're seeing now these sparks of AGI where when we see ChatGPT and we see these other tools, they're becoming to the point where they can be generalizable. So when we get GPT-5, what is the main difference between GPT-5 and GPT-4? Well, it's going to be smarter. It's going to have better reasoning. It's going to have better capability. But these 5 things really stand out. So looking into the biomarkers of aging, like figuring out, if we have a therapeutic, can we actually robustly have a quantitative model that something changed when we alter our biology, instead of having a subjective feeling. So that's one big area. Drug discovery and repurposing. Think of like in silico medicine, where they're able to now simulate a biology with computers, with AI. And really that's going to dramatically increase drug discovery. Think about the Moderna vaccine. That vaccine was actually developed within a matter of days, even though it took months to actually test it across the human population. And it's just one example of how fast things are becoming. And we're on the cusp of being able to model protein to protein interactions at a scale where we could actually develop drugs much faster. And eventually what we'll be able to do is when the AI comes up with a new drug, we'll already know what the reaction is going to be in the body. We'll be able to predict that using AI. And AI can read everything on the internet. It can consume all of human knowledge, and then it can have a model in its mind, and it could basically make discoveries and inferences based on that model. Personalized medicine and nutrition. So, this is where things are kind of going today. So think of, we have wearables, we have all kinds of different levels of nutritional guidance, and it's going to be driven more and more by AI. Think of if you need to write up a nutritional plan, or if you need to decipher something from your health data that's being tracked, such as with a wearable device like the Whoop or the Oura Ring, and so on. The next one, early detection of age-related diseases. So this is going to be your advanced diagnostics. So what you can do is you can get a lot of different tests and scans. Think of an MRI, but take it a step further and generate gigabytes and gigabytes, hundreds of gigabytes of data across your body to be able to really see not only disease states, but the precursors of disease states. And that is something that can be done. So for example, detecting cancer, you're able to actually detect a cancer being predisposed or having the precursors well before you actually have a tumor. And this has been studied quite a bit. And I think that early diagnostics right now is one of the more powerful applications of AI, and it's only getting better every day. The next one is going to be understanding aging pathways. So this one, we're still in the early stages of really understanding aging, even though there's so many papers written about it. But when I started talking to people more about this, I realized that we really don't have a clear definition that everyone agrees on, and there's a lot of disagreements in the field still about what aging actually is. But it does look like we're making progress, and really you want to determine when a change is measured in your body, is that an actual cause? Like, did that cause age-related damage, or was that just a passenger along the way as a byproduct of some other process? So it's very complex. I don't think we're there yet, but at the end of the day, we actually won't need to understand all the pathways to reverse aging. We'll just need to understand enough. And really, once we have more therapeutics and we can quantify and measure the changes, we'll then start to decipher what were the pathways after the fact. So what are the current tools of today? So far, we have ChatGPT. Everyone knows about that. GPT-5 should be released likely by this year, and it's going to have more and more capabilities. Recently, we had Sora, OpenAI really released their text-to-speech, text-to-video, and their text-to-video is truly amazing. It was interesting because as they implemented the model, it would produce a real-time image. Say you want a dog on a beach jumping around in the water, and it could then make that video. And as they noticed that when you scaled up the compute, that it actually got more, the quality of the video went up. So you could see like the distinct features of the animal. You could see the very specific characteristics. And from there, what happened was they can now simulate entire worlds. So these are now simulated worlds. And it's amazing because the AI system could actually have some level of understanding of what's in that world, because it could understand physics. When something falls, it drops to the ground. And I don't think people realize that that's actually pretty hard to conceptualize for a machine. So the capabilities are definitely going up. Once we can simulate more and more of biology and more of different things within aging, we should be able to see quite a bit of breakthroughs happening even faster. Then we have Google's product, Gemini. Gemini, I really like because it interfaces with your Google products. And so think of like your Gmail, for example. It could read your emails, and then it could come up with responses for those emails. And it could look at Google Maps and so on. And so Gemini, and now they launched their advanced version that costs money, but definitely we want to keep an eye on that one, and using all the tools to really help. Right now, they're really good like learning machines. So if you wanted to summarize something or read a paper and so on, they're really good for that. And I'll show in a minute one of the features of an OpenAI product that I worked on. And soon we'll have what are called agents. So agents are going to be, you can think of something on your computer that can actually do things. So if you you can think of like you're sitting there, your hands are off the keyboard, and suddenly the mouse is moving on its own, or a Google Chrome, you know, window pops up and some search is happening. Maybe it's writing a paper for you. But agents by definition have agency. And so they're going to be able to actually do things for you. And that should accelerate progress for everyone to learn more and to really just do more. And that will be a key component towards artificial general intelligence. You have to have several pieces. So you have to have agency, you have to have likely internet connection, and some form of simulation of a world to have general intelligence. Okay, we'll keep going. So here is, I'm going to demo two things very quickly. First one is going to be, it's called Ageless GPT. So everyone can go make a GPT on the GPT store. And with that, it's fairly easy to make. And you can then give it information. So you can feed it PDFs and things to alter its model, or say its brain to some degree, like its learning ability. So I'm going to show what that looks like real quick. Here is this one I built. It is called Ageless GPT, and you can see here, you can see these PDFs that I've uploaded to there. So I'm going to give a short example of how it might change its functionality when you upload something. So say I ask, what are your thoughts on Clotho based on your current knowledge? Please keep it concise with bullets, please. Say short, please. And now we'll see its response, and then I'll feed it a PDF just to show that the output should change. So you can see here, it's talking about Clotho. And while it's doing that, I'm going to get this PDF for us, and I'm going to feed it in here. So I'm going to go upload files. Let me see if I can slide it in here. Okay. All right, so now once I push update, it'll then have this file in your brain, in its brain essentially, or in its model. So I'm going to go update, confirm. And now I'm going to ask it the same question, and I want to see that its response has changed. So you can see its response here. So let's see, first, this was its response, and now its response should be slightly different. But you may be able to also reference that file, like say like, hey, based on this Clotho research that I've just uploaded, what did it say? And you can see here it is diverging slightly. Like you can tell that the actual response is different. So we won't go too far into the details. Okay, I'm gonna keep going on one or two other things, and then I will take questions. And so the other part I wanted to briefly show is the platform to track biological age. So this is something that is in the early stages. Here's the prototype. But the idea is that we have 78 plus organs in the human body, and we want to be able to track biological age across every single organ. And you can think of each arrow on here as pointing to a specific part of the body, and the red ones being above chronological age, sort of as a flag. And so you could think of an AI model that basically takes a lot of information and then spits out an inference or an approximation of the age of a specific organ. So, for example, heart age, you may have an MRI, you may have a functional testing, blood-based testing, and so on.
Przypomniał toho Miezę.
You're off mute, Gunther. So anyway, so that is how that would work. You would have an estimate, and you would want to know what went into that, and then here you'll be able to talk with something like ChatGPT or another AI system to effectively ask about things like, hey, what is driving my heart age to be higher than my chronological age? And if you've done 50 different tests that made that approximation, you'd be able to then get some information from that. And it should get better and better as you can interface with your voice and with text to be able to discuss with ChatGPT or with Google, one of Google's AIs, and really have a real-time interface to figure out more and more as you get better and better simulations in silico. So let me bring back this figure again. And that's pretty much it. You can see I have you can check things more out on my websites. I have coaching services as well. The main thing for me is to take this inflection point for people and really push that way far back using a multi-step rejuvenation protocol that I put together over the past few years. So instead of really seeing this change in this line becoming vertical around 77 or 80, I believe that we can push that back by decades with current tools and eventually flatten this curve completely. I'll drop a code in the group chat for 10% off. I'm selling a lifestyle guide. It's called the Ageless Guide. You'll find it on my website if you're interested. I'll drop that in the chat, and has a lot of different things from exercise to nutrition to some of the more advanced tools that we're all looking into as well. Thank you very much. I'll take some questions. Chris, you want to know your hands up? You want to start us with a question or?
Yeah, so I was just curious, I don't know if the chart where you talked about the intelligence of humans versus eventual ASI, whether that yeah, exactly, whether that was based on anything or was it just like a whimsical guess at the magnitude of where we might go?
Yeah, it's a good question. So there's this guy named Nick Bostrom, and he came up with his theory of superintelligence. He's been studying this for many, many years, if not decades. And he lays out his theory, and really it makes a lot of sense. You could see his book. I can drop in the group chat his book. But he lays out that there's no reason to think that human level intelligence is anywhere near what is the maximum amount of intellect we could have in a small amount of matter or space. So just in, a normal computer, like a normal size, there's no reason to think that like a brain is so optimized that it could be the best. So really, he goes through a lot of things on how he comes to this conclusion, but yeah, it's definitely not whimsical. It's based on all his research over many, many decades, and it just lays out that as smart as humans are, we're only as smart as evolution has made us. And now that we're doing more of a designed or targeted or a different form of evolution, right? Because of these tools that can enhance things and also just build on a whole different scale these supercomputers that are going to cost, billions and billions, if not trillions of dollars to make. There's no reason to think that we can't create something dramatically more intelligent. And I'll drop a link, but it's called Superintelligence, his book. So
Yeah, thank you. I'm super interested in that, both as a numbers guy, but also an avid science fiction reader and aware of several, end game superintelligence that have been proposed. And yeah, thank you.
One thing I'll add is that when they were training DeepMind and when Google was looking into these systems, DeepMind is a subsidiary of Google, and basically this machine they were building was playing Go, and there was this move 37 in the game. It made this move that no other human could make. And everyone looking at this game were like, I don't understand that move. But in the end, when they really looked at it, and these are the best Go players in the world, they realized that it was an extremely good move. And so I see once we have AGI, I think it's going to quickly become a sort of a weak form of ASI nearly immediately, actually, because it could read everything. And if it can make these Move 37 discoveries, right, say in physics and chemistry and biology, and just having the ability to make decisions that are substantially better than a way a human can, you know, it's one example of a narrow application of superintelligence. And I think that once we have that general form, it could make these Move 37 decisions all the time, and that's where we'll start to climb this ladder.
Yeah, I'd heard that story. That's actually great. Thank you.
Of course, thank you. Let's see, other questions. I do see Walter's in the chat. Accessing Ageless GPT, I will drop that in the group chat for us. It's public and it's free to use too. So there's a link and I will share that. But really, if someone was searching for it, you could go and you could Google Ageless GPT. You should be able to find it. Also, if you just look in like the GPT store, that's one way as well. Okay, Miles.
Yes, thanks very much, Jason, for the talk. Can you hear me?
Yes.
Yes.
Okay, just a comment, because I see OpenAI, they are inviting people to join their forum. I have applied to be part of that forum, and obviously none of us own any shares in OpenAI, but I do think that my comment is that I think that Sora is really a game changer, because there is something interesting about it, in that the sense that in order to do the videos, it constructs an internal model of what it is seeing. In fact, it's a three-dimensional model, and it kind of deduces the pictures of the video from that three-dimensional model. So I think you should. I'm giving the suggestion. Just poke a little bit around OpenAI, maybe join that forum, because I think if we're going to get to a point where we will be entering the genome into something like Sora, and it will generate the human body. It will generate the three-dimensional model, including the disease levels, things like the molecular reactions, the cellular interactions, the things like nerve impulses. It's going to be able to do that by taking the genome as its prompt, as the prompt. I mean, I think this is a fairly obvious thing if you look at what it's doing, because you need that kind of three-dimensional and spatial and time lapse model to be able to understand the human body, and the human body is incredibly complex, but these models are able to deal with amazing complexity which we as individuals just can't do. We just can't keep our attention long enough on something so enormous, but these models have no problem comprehending the entire human body at the same time. I mean, you can see this. So yeah, I think I'm very excited about Sora, the video, text to video model, because I think that's going to be used to do basically genome to phenotype modeling in the future.
100% agree. And I'll just add to that. For example, companies are making these digital twins, exactly kind of how you're describing, like having an in silico model of ourselves. And this is one example, this Q.bio, that basically, you know, what you're going to be able to do is scan your entire body extensively, you know, whether that's through MRI, ultrasound, blood-based testing, functional testing, and really much more. And there's a lot of companies like this. There's actually probably hundreds of projects that are all working on sort of like what you're describing. And I think Sora is definitely a game changer as well. And I think our ability to get what is happening in our world into the computer so we can then build things much quicker. I think we're finally at that inflection point where, you know, we have now hundreds of companies attempting to build that. And while we don't know which one will succeed, I think that someone will, and it'll change everything. So this is a good example of what you're describing. Awesome. Thanks, guys. We'll really appreciate it. Any last questions? Right.
Well, thank you, Jason. We are indeed fortunate to have you as our resident AI guy. I recently moved to the great state of Florida to work on what I am convinced have the most promise for aging intervention or age reversal or whatever you want to call it. And that's, I know there are a great number of therapies that all of you are practicing, as do I, but I felt that being in Florida and being active in these two therapies specifically held the most promise. So the first one is Yamanaka or OSK gene therapies to reset the epigenome towards youth, or sometimes known as cellular reprogramming. I'm fortunate to be a part of that and make some contributions. I'm not leading it. We have some truly world-class scientists on our team who are developing the project plan, and we're slowly moving ahead on that. Plasma-based therapies, in my estimation, are very, very important, likely to produce very great results, and they're actually available now. And I'm happy that Diane and Tom are here with us today, and they're doing some really exciting things in the free nation of Texas. And I'm hoping that after I talk about what I'm doing, that they will talk a little bit about their initiatives that are really getting some, from what I can see, some great results. So I will now share my screen. And you can find out about this and a whole lot more on my website, agingintervention.org. And it forwards to the foundation, to the actual website, aginginterventionfoundation.org. It talks about the mission and the number 1 and 2 things I'm doing. The one is the components of the plasma project, and then a little more about the epigenetic age reprogramming and some other things that I've been active in. And I call it Project Starshot. Moonshot, yeah, been there, done that. This is like many, many moonshots, solving the problem of biological aging. And, we've never really accomplished big things by thinking small. So, like most of you, I'm thinking big, open-ended, healthy life. And of course it's healthy, and also making the world a better place. And if you care to see a little video about it, there's one here. This is kind of whimsical. It talks about the value of time, which is really what we're in the business of creating. And, one thing almost everyone can agree on is we need more time. So that's what this is about. This is a graphic that is kind of cuts to the chase. At the end, when we're facing the Grim Reaper, you see he's pointing over here. You leave all your money, your crown jewels, your trophies, everything you have behind. And also, what are we going to do with all that extra time once we do solve aging and have total control over it? Well, travel, party, yeah, a little, but I'll just suggest, join me, have a purpose, make the world better. And these are some of the things I'm going to work on after we solve aging. And if you go down a little further, I won't take you there now, there is an aging intervention program, and it consists of the systems, therapies, and methods, which to my mind are the 3 main components, and it's kind of a roadmap for you. At the start, Jason talked about the definitions of aging, and they're And one of the first things I talk about are some of the various definitions of aging. But let's get to the plasma project. You can see it, this little write-up I'm going to show you, by clicking on this link. And that takes us here. And it talks about, this is an initiative by our nonprofit, the Carl I. Boerhaave Medical Research Foundation, doing business as Aging Intervention Foundation. And that's the subject. And I introduce myself, and I just talk about some of the therapies I've been active in for a number of years. But in my estimation, of all the therapies that are available right now, plasma-based therapies have the very best potential for age management and reversal. And this link takes you to a background summary that's kind of specialized. It talks about, I've been active in and out one way or another in various forms of plasma therapies, either doing them in the form of a number of umbilical cord plasma infusions, and later Therapeutic Plasma Exchange, and now the Therapeutic Plasma, out with the old, in with plasma from young subjects. Been working on that on and off since about 2015. So this talks about some of the high points of that, and then goes on to some other things. But going back to this, there's a little video, and it talks about why I'm so personally heavily invested in this at this point. I want access to these therapies myself, in addition to having a humanitarian effort and wanting to be of service to members of our community, all of you, and the entire world. And also there's good evidence that these therapies may assist in early dementia and Alzheimer's. So that's a very serious, if not the number one problem plaguing us today. There are some articles at the end of this little write-up about the research and some successes, and unfortunately, we just don't do what we want to do. There are strong regulatory guidelines that we have to adhere to and put systems in place. So this project has an investigational review board, and probably most of you know that IRB is the are the letters for that. So this is fully compliant with all regulatory guidelines, and there are kind of a lot of them, and they cost money. And so this is a IRB approved clinical study, and my intention is to make this accessible and affordable to our community at the lowest possible cost. This can be looked at as an extension of earlier parabiosis studies, where an old mouse and a young mouse were joined together, and their circulatory systems commingled their blood. According to the biomarkers and the results of these research studies, the old mice became biologically younger and the young mice became biologically older. So here's a reference for that. And this is where it gets interesting. There is disagreement in our community whether the reason this occurred is pro-aging factors, old factors in blood and in plasma being removed, or whether youth-enhancing factors were the result of these as a result of the young blood into the old mouse. There's disagreement about that, but in this study, we're going to find out. But anyway, here, this talks about what plasma is. It's a component of blood, and there are three arms to this. This is a comparison study. The first one is therapeutic plasma replacement. I just call it TPR. I believe that's standard. Here are some of the youth-enhancing factors in blood from young people: extracellular vesicles or exosomes, stem cells and progenitor cells, cytokines, growth factors, metabolites, the other things that you read here, okay? And in plasma in young people, these are believed to be in a balance that's consistent with youth. And that's an important thing, is the balance. We hear different research initiatives about 1, 2, 3, maybe 4, or a few more things, but I'm suggesting that, and what we hope to shed more light on, is that the balance of all these things, and probably others, probably a lot of others that we don't know about yet, are what are really important and will be much more effective than just one or a few things. The second one, therapeutic plasma infusion, that's just a straight infusion with no removal. So that's the second arm of this study. The third, therapeutic plasma exchange, which is the removal of plasma and replacement with saline and albumin, and also usually with an IgG push to make up for any lost immune components. I'm going to be the first to say that for me, the TPE, the one TPE I had the best objectively measured as well as subjective results of any age management therapy I've ever had. And and I've had kind of a lot. And my expectation is that when I'm patient zero with my own study, with the removal of my plasma and replacement with plasma from young donors, that the results will be even better. That's my expectation anyway. We shall see. So this document goes on to talk about some other components, and here's some of the team members. And if you want to participate, here's how to find me. Here are a few references. That's basically what I have to say about it. I will stop sharing the screen. Any questions about what I've presented?
This is Albert. May I ask about your personal results? You mentioned that you had very impressive test results and changes in subjective results as well. I'm curious.
Please do. Then on to Miles, but go ahead, Albert.
If you measured your RDW, red blood cell distribution width, before and at different time points after, did it go up or down, and has that persisted?
Okay. Oh yeah. Well, there's one thing there that I left out. Okay. Albert asked two questions. The first one, RDW, I'm fairly certain it decreased. And the reason, and I'd have to look it up. I'd rather not do it right now. I'd have to dig through my documents, but I rely, and one of the tests for this that I did that was the least impressive to me, but still a nice result, was the phenotypic age calculation, originally designed by Morgan Levine and Steve Horvath. And RDW is one of the, I think it's 9 readily available low-cost biomarkers that go into that calculation. So we'll, in the open discussion, when everyone's talking, I'll have a moment to look at my exact numbers. But my phenotypic age, according to that one very nice biomarker, and it's convenient, low cost, it decreased by a little less than 4 years. But I have to give a full disclosure, the initial number was a little higher than I expected. So I'm confident, I mean, n equals 1, this is not an exact scientific experiment. I'm confident that it decreased my phenotypic age number by at least 2 years. Okay, now while I'm on this, did I address both your questions already, Albert? I forgot what the second one was.
The second one was whether the change persisted. Do you regularly get a CBC done and check it when you do?
Yeah. Let me tell you my other biomarkers first, and then I'll give you what may be a bit of a downer. Should I give you now? No, I'll save the downer later. Good news, bad news. Okay, the other things that I did not do a full, complete set of biomarkers. I have them in my study. We're doing a fairly comprehensive low-cost set, and of course, participants are free to do whatever biomarkers they want to do. And I hope you do a lot of stuff, but I'm trying to keep the cost down here. The one that was really, I don't know, I don't use the word amazing a lot, but in my home gym, I have an elliptical machine, and I do my high intensity interval training on it. And I also use it as a gauge of the various therapies that I do. Normally, I hit about 99 strides in the first 25-second burst, which is, pretty good. I'm at age 74. I don't call them years anymore. They're going by fast. I call them blinks. At age 74, I'm that's pretty good. But on a good day, I hit about 104, 105. In response to another therapy, I was hitting about 109, 110 as a test, but then that fell off. Shortly after the TPE, 119 strides, and I felt I could keep going and going and going. So, yeah, but now, okay, another thing. The other good news, I rely on different cognitive tests. And in recent years, I love lab tests, DNA methylation, inflammation, certainly safety. You want to watch the liver, kidneys, other things. But in terms, I've turned more towards functional testing, because that's the real closer to the end result that we're seeking, which is really having a great life filled with vitality and joy. So I rely on the human benchmark tests, in particular the number memory, and there are experts who believe number memory is the most important indicator of brain health, also verbal memory, and also reaction time, which spans cognitive and physical. But my number memory, normally using the human benchmark test, is about 8 or 9 digits, according to that test, which is pretty good. After the TPE, I could, for a number of weeks, remember 10 digits. Now, I suggest to you that the marginal difference between 8 or 9 and 10 is kind of a big deal. And I was even in a meeting with a scientist once, talking, taking the test, showing him what I was doing. And this is funny, he was distracting me, asking me with questions. So I just went on, take the test. I could still do 10 digits. So I thought that was pretty cool. I've covered, also I had seen Irina Conboy's presentation at the 2022 RADFest about the results of their TPE study. And she showed a number of results, but among them were the shift in protein profile towards you. And I really like DNA methylation, but members in our community report different results with that, and I really like it. But to my estimation, the protein profile is closer to the end result we seek, which is our function, our daily living. So having said that, that's the good news. Now, to Albert's question, the less than desirable news is that, according to my estimation, from the best I can tell, with both subjectively and objectively, the results lasted maybe a month, maybe a little longer for the number memory. So I'll take it. So, on the subjective side, I don't always rely wholly on subjective, but I knew something was going on. And I became more active and interested in the kinds of vigorous activities I was interested in my early 20s, 30s. So there you go, Albert. If I've answered your question, I believe
Yep,
I have.
thank you.
Johnny, if I might. I don't know if you want to share this or not, but I'm very interested in TPE partly because I have a few mostly well-managed autoimmune issues. And so, occasionally the antibodies pop up, and I wondered if you tracked any of that, if you have any of that you can talk to. Maybe you don't.
Well, that is not a part of the study protocol. But anyone who participates, I encourage them to do their own biomarkers. I mean, what's to stop you? And I'd like any and all results.
Okay, thanks.
What state are you in?
I'm in Maryland, but I would happily travel to Florida to participate. I have a son down there.
Okay. Well,
Hey,
very good.
Chris,
Yeah.
one of the best kept secrets in the medical community is that the frequent donation of plasma is a plasma exchange. And you can actually get paid by pharmaceutical companies in more than 1,000 locations throughout the United States. So in my background is our plasma collection center. And so what you see there is an apheresis device. So the difference is when you donate plasma, you'll donate approximately 750 mLs. And when you go in for a total plasma exchange, that could be as much as 3 liters. And albumin is commonly introduced to just balance your osmotic levels. At the plasma exchange that you deliver really at a plasma collection center, for which they will pay you, you get those detoxification, those dilution benefits. And Johnny was correct because apheresis has been around for 50 years. It's performed 30,000 times a year in the United States at about 35 medical centers. And very importantly, it's performed 150,000 times a day by blood banks and plasma collection centers because it's all uses the same device. So the difference really is volume. And Johnny was correct that with 50 years of experience, inflammation builds back in about 10 to 14 days. And so if you donate plasma once a week, you can stay ahead of that curve. It's available to you. You don't have to go to Florida. It's right probably in your own town. Takata, BioLife, CSL, all of them will perform that process. Don't do it more than once a week. But if you do it once a week, by the end of the month, you just got a total plasma exchange.
Yeah, I'm very interested actually, but I
Yeah.
do have a question. I haven't done enough research, but I called one place and they said they don't take O-tape blood people. Is that true, or is that just that
Well,
one
yeah,
place?
no, that's absolutely correct. It is not blood. It does not apply to blood. Because when you donate reds, I run a fully accredited blood bank. We don't collect blood because we're specifically all about plasma. Because what happens is when you donate blood, you lose your cells, and therefore there's a slight debilitative effect from that. So you can only donate blood 6 times a year. Plasma you rebuild in 48 hours, and legally you can donate plasma 104 times a year. We don't recommend it. We don't allow it to our standards because you don't want to deplete your protein if you do it that frequently. That's plasma collected by pharmaceutical companies specifically for the protein. But if you do it once a week, there's no age limit. They will pay you, and you're receiving a plasma exchange.
Yeah, thanks. Could you drop the names of those labs in the chat? Maybe I need to look into that more. Thank you, Tom.
Or it's ppta.org, Plasma Protein Therapeutics Association.org, and they even have a locator for you.
Okay, thank you.
How old? Well, I won't ask how old you are, Chris, but I'll just say that these centers, if you're above age, they won't. Most of them won't take you if you're above age either 69 or 70, and I believe that's a hard and fast rule. But if you are, BioLife may take you. but you have to get your doctor's approval. If you have, they pay special attention to medical conditions, and just one thing that you might not think would matter would knock you out. So many of us here are over that age. So just be aware. But BioLife is the name of the one, BIOLIFE, that will take donors over age either 69 or 70.
Okay, yeah,
And
thank you.
you'll
I
have
don't,
to jump
I don't
through
mind
some
admitting,
hoops.
I'm 65, so I haven't hit that number yet.
Great.
All right,
and
you'll find there's a lot of them. Grifols, you have Biomat, you have CSL, which is actually the largest, which is owned by Behringer. So go to that PPTA and they'll give you the whole, you have Octapharma, you've got actually dozens of companies. And since they sterilize the plasma they collect from you and it's not used directly for human use, some of them have actually fairly loose standards, so to speak, looser than blood banks, which are collected product biologics collected for direct human use after testing. The pharmaceutical companies have that sterilization process. So there's a lot of them, and some of them you may find are pretty accommodating.
All right, thank you, everybody, for that help. I really appreciate it.
Okay, Albert, your hand is still up.
Thank you. Just a quick question for Tom. Can you tell us if your setup or any others like it that you know of is measuring the donor's carbon monoxide level before or after the apheresis, which from what I've read is going to usually raise their carbon monoxide level from the damage to the red blood cells that are returned?
Wow. No. And again, it's performed, we collect a lot of plasma. And it's these types of procedures are performed 150,000 times a day. They've been doing it since really right after World War II. So I think, that's not a defined problem. So sometimes things are interesting, but disproportionately immaterial.
Okay, Walter.
Hi there. I had a thought that I don't have science behind, but everybody knows that that one of the characteristics of advanced age is the withdrawal or the degradation of repair mechanisms that characterize young people. And I was thinking about what you were saying about how the effects go away after a week or two or something like that. But you could think of it slightly differently, that during that 2 weeks, I'd like to think, I don't know this, but I'd like to think that your restoration mechanisms have been revitalized and you're fixing things. And those fixed things stay fixed for quite a while. So if, say, for instance, you have a degraded kidney and you do you take the magic sauce and your kidney is restored. Well, the sauce may, because it's not being endogenously, perpetuated, the sauce may go away, but the kidney is going to stay good for quite a while. Just, I think that, even if you can't remember the numbers, I don't quite know the physiology of memory, but just a thought.
It's actually really a temporary benefit, and that you'll find that they often apply it once a week. I live in San Diego at UCSD, which is one of the major apheresis centers. They have an individual, they have performed a total plasma exchange more than 1,000 times. So there's a certain point where it keeps you clean. It's like changing the oil on an old motor, but it doesn't fix the parts. And
Can I address that? Can I address that?
Please.
You can't, from the laws of physics, rejuvenate molecules that can't be rejuvenated anymore. If you read the Convoy paper, I think the one you guys are talking about, or the one she talked about, the one that Metapore was the first author, they clean out in the 4 rats that they did, they clean out whatever they want to do with their exchange, and she sees small growth in the little areas of the hippocampus. We're not talking about re-stimulating anything where she says, oh, you don't see that as much when you add the young stuff. The concept of adding the young plasma proteins are rebuilding the extracellular matrix with molecules that you are physically incapable of making and will not be capable of making again. You can clean your car engine out all you want. You have to replace the battery. The second law of thermodynamics says that things head to equilibrium. They spread. So every time you have a chemical reaction, which is your metabolism, the byproduct, you make just a little more kind of dust. So you can say, okay, my old stuff is getting gummed up. So now I'm going to clean out some of that gum, but the busted or aged or whatever you want to call it, extracellular matrix and the proteins that are no longer capable to be made, you can't rejuvenate back to the level of when, you know, you were 20. So the concept behind adding the young plasma, that's why to me, TPE is all well and good, but I agree, you can do it for free. And we aren't even doing a lot of TPE now in a lot of our docs. They're just removing 500 or 600 cc's of blood and then hanging 2 liters of plasma in. So the whole purpose is just to make room for the young molecular factors that will now soften the extracellular matrix that has been glycated up. And now this extracellular matrix cell signaling improves. So it's really the replacement of the young factors that you just can't make anymore. So you may get a little bit of relief if you remove the bad stuff for a few days or a week, but like I saw my dad's heart failure markers stay low for 4 months because I actually didn't give him enough plasma. The person, if you look at our presentation that we gave the 3 liters to, his heart failure markers stayed low because the young proteins got into the heart and the fibrosis got better. It did things that the old body is just no longer able to do.
Well, aren't you saying exactly what I just said, which is you've actually, to some degree, restored his heart function, and that will last after the chemicals go away?
Only with the replacement. It's not, I just wanted to differentiate TPE itself from plasma volume, young plasma added.
So putting young plasma in, you're saying is needed also to regenerate, rejuvenate.
That's my point. The TPE, I don't think does much of it. It's nice and it's icing on the cake, but what did the job was to dump the young factors in. Yes. And so
Yes,
that's,
Diane, are you sure that actually you can just change rigidity of matrix because it's covalent bonding, so all over the place because of Maillard reaction, it's very hard. Maybe it has some different mechanism rather than just reduction of rigidity of this intracellular matrix.
I follow Colin Ewald, who is a big researcher, big PhD researcher in New Zealand, and he'll talk about the addition of things that go in that actually reverse some of that rigidity.
Yeah.
Is it possible that some
EWALD.
is it possible that some people respond better to one or the other depending upon their condition?
Well, I think like anything, right? Whatever's busted is what you're going to try to get better. If you look at my brain works because I have this, and my skull, my nutrients go to my bones because I have this, and my blood sugar is here because of this. So I think the concept is you put the young stuff in and the molecules are going to disperse and go where they need to go. You know, for me, my running recovery got better. So significantly improved, and I'm already fit because I'm 4th on the rejuvenation Olympics list. I'm in front of Brian Johnson. I'm 4th. So I'm a fit person. I'm not a big epigenetic person because I think that varies too much. I'm researching a lot of, I think blood markers and blood proteins are better, but I still threw my hat into the rejuvenation Olympics. So I'm a pretty fit 59-year-old lady. But I think that the big key is you can put more back into the system and it will go where it needs to go.
Okay, other questions? Albert, do you still have a question? You're in front of David on
I
my
know, I
screen.
apologize.
Okay, David.
Hi, this is a message for Tom Casey and Diane Ginsburg too. There's
Oh,
a
hey, David, you're showing
Oh.
the low camera. There you go. Thanks. Yeah.
sorry. Okay, Tom and there's a paper published last year. I'll get the link in a second. It's cautioning about the leaching of phthalates from medical tubing and IV bags and so on in these procedures. Are there any viewpoints on that? I'll put it in the chat.
I'll read it, but I would basically say no, because I practice medicine, practiced OB-GYN for 35 years, right? I've poured more plasma and blood into people at high volume than you can imagine, and we've never seen any of that being an issue. It hasn't reflected it in anything, so I can't imagine. I don't know. I can't speak to if you did some massive 3-liter exchange. I mean, with all that tubing, I think that's a different story. But to me, if you read some of that stuff, like if you read in the AMBAR study, half of those people had chest tubes and central lines and stuff. So I think that big volume, it's a whole different animal. But from
Well,
straight,
I wasn't concerned about a single time. I was just thinking maybe I want to do this once every month for the rest of my life. And I'm thinking over years of increased phthalates into my blood. I was wondering might have some sort of long-term effect. And it's in this paper I put in the chat.
So I will read that, but I would say from what we're finding and from what we're seeing, you're not going to need that kind of volume. Now maybe you'll do 200 cc's every month.
So I'm
And
new to this.
yeah. So basically the concept is, and that's what we're following, right? Do you do a 3-liter dump and then maybe you only need a liter every 6 months? Like that's part of our study that we're looking at. One of the big problems you have, and I've researched this in detail, is I don't know that epigenetic testing truly reflects the benefits of plasma. You dump high levels of proteins in people and the methylation system says, I don't have to work that hard. So I'm seeing very weird things with the epigenetics. So right now we're trying to figure out A, best testing, and B, what do you do? Like I put 3 liters in both of my parents again in November over Thanksgiving when they were in Texas. So I'm following them. I'm sticking them left and right. I'm doing all kinds of testing to kind of look at them. But from what I've seen, like I don't know that they need anything for at least 6-8 months. That's if you do a big dump. But you know what Stanford did is they did like 200 cc's every week, but you may be able to be, it may be okay, you only need 200 cc's a month. So I don't think you're going to need large volume on a regular basis, that it's going to disturb that. But
I may do this once a year. And in that once a year, I'm only age 55. I may want to do this the next 30, 40 years. And once a year, does anyone, Tom, do you have any idea how much of these phthalates we're getting from the IV bags?
Well, I've got to say that I'll have to read that paper, but I'm originally from the IV business. So I'm a person who produced those bags and produced those tubes. And then I started a company called, became named Caremark, which literally performed 20,000, still performs 20,000 IV infusions a month. So I've been around IVs where you've seen people on them continuously for years. We did total parenteral nutrition, through a central catheter line from bagged, compositions of nutrients. And that was all these people lived on. So what I see is, and we all know all things are relative. So, and I'll tell you a kind of a heartfelt story very quickly, but don't let minor fears, because we do 2.1 million multiple unit plasma transfusions a year in this country that are documented by safety. So don't let little possibility, it's almost like conspiracy theories, because I'll give you an example. Because of people being unnecessarily and really irrationally concerned about vaccines, we have given that 95% of America is vaccinated, it's a little bit of a interesting, but we have a designated donor program. that if you have somebody that's, you want to donate for you and you want to get into that and manage that, then we allow it. And so we had somebody who was concerned about a non-existent spike protein because COVID's not carried in plasma, enter the designated donor program for his wife, who was very ill. And the sad part of it is, it took so long to start collecting that plasma, she passed away. And so I don't know if there's any association or anything, but I looked at it and said, she really could have benefited from that plasma in a tangible sense. We've done hundreds of patients, filled prescriptions. Diane Ginsburg is the only MD who's been the principal investigator of 3 consecutive human studies, going back to one for Parkinson's and MS at the Texas Medical Center. So you're talking to a lot of experience there. So
And I just read the paper. I just read the paper. So if you read the paper, basically the problem was nipples, pacifiers, milk bottles. They got it more from that. And here, if anything, it says phthalates in medical devices and IV fluids were lower than those reported in earlier studies. So neonates were the problem. It's all the volume of the neonates. But I just read the paper. And the adults were actually lower.
I'll just jump in and suggest I would expect something in the plasma might clear out the phthalates. And also let's look at dialysis patients. They get their treatments, week after week, month after month. How are they doing? And then, third little point, we do know the outcome of no age management therapy. Aging is 100% fatal. So it's a balance and it's a carefully calculated risk.
I have something I'd like to add for you, David. I probably received more young plasma than almost anybody over the past 7 years. And I've been doing it sometimes on a different schedule, but the last time I received 3 liters was a year ago. So you said you were 54. You would be unbelievably smart to stay ahead of the curve before you are damaged by doing a treatment once a year and keep yourself, basically with all the raw materials, as Diane says, that your body no longer produces. I myself, if I could, I would do it twice a year. Stanford had some benefits go 2 years. Out of some of Diane's studies, some of the diabetics have benefited for 4 years. So it has a long effect, but having received it myself, your body really likes it. And you kind of get energized and everything. And then it starts whispering to you, which I'm going through right now. Why don't we get a little more of that? So it's good to start and stay on top of it.
Yeah. Well, let me just add, be honest, Tom and Diane both look young. So that's one indicator. Well, and so far, Diane, Albert, do you have another question?
Yes, please, for Diane. Same question I had for Tom and Johnny. Can you tell us if you have any information on the RDW trends in you or your parents after these treatments?
The problem with my mom and dad is in our own learning curve. I did November a year ago, not this past November. We did a liter out, a liter in, and I was stupid. A week later, I did a liter out and put another liter in. So my dad had really good results in his BNP, so his heart failure markers got better, but I took a bunch of the young plasma out. So I probably should check them sooner. I'm looking, but I was going to wait 3 to 4 months. So I'll have a better RDW result there about 3.5 months now, and I will post that. I'm going to do I've been talking to the Deep Longevity, to the guy that runs Deep Longevity, and I think we're going to start using his blood marker test for our study. So I will have not only blood data, but RDW data probably within a week or 2.
Well, that's good. And can you tell us what your last RDW was?
I did my liter. I hadn't done in a while. I ran a marathon in October, and then I did a liter in December and a liter in January. So I'm going to also do my CBC this month. I didn't want to do it in a month. I thought it was too soon. I was going to wait 4 months, but I think I'll do it this month and I'll let you guys know. It just hasn't been long enough.
Okay, I've seen people's RDW change 3 or 4 points in a week or two, either going into a hospital in an ICU situation or coming out alive again.
I believe that that's what bothered me a lot about the epigenetic test. I saw massive changes. The pace of aging, the true diagnostic pace of aging seemed to hold a little bit of stability, but the omic test was all over. So after the plasma. So it's really, again, looking at the RDW, it comes down to, is it going to be stable? Is it going to change? So I'll do it, and then maybe I'll do it every couple weeks. I mean, I can write my own order, which is one of the cool things about being an MD. So I can go. I did a lot of that one because I do a lot of hormone replacement. So one month I went every day and got my estradiol level from LabCorp. They thought I was crazy, but I'll do maybe I'll do my RDW twice a day. That would be pretty cool. I'll go in the morning and then I'll go in at night and see what the variation is.
For those who want to do it more often, from my reading of the literature, I would recommend weekly at the most. That's the time scale on which you're likely to see changes of a point or more. But for most people, unless you're going in or out of an ICU, expect change over a month or two.
I think it would just be cool to see variation even within a day. You know what I mean? It would just be cool to track.
Yeah. Hopefully you wouldn't show any, because it would mean you'd have to have a pretty significant change in your blood distribution between young, middle age and old age red blood cells.
Right, but it would be neat to have that stability, right? To me, that's the cool part of it. I get it. So what would be really cool would be to show every day I did it, and then did it twice a day, some of them, and the number is same, stable, and then boom, you see the drop.
Oh, I follow you now. Yes, that would be very cool.
Yeah.
Good luck to your arm.
Jason?
I had a question. If anyone has used peptides or ultrasound in combination with a young plasma exchange, maybe on the same day or within the next few days, if anyone has used those in combination.
I have a close associate who did a TPE followed by peptide or by exosomes by Farshin, and he didn't do a lot to or anything to objectively measure the results, but he uses his how he feels as a good indicator, as subjective as it may be. He says he had very good results with that combination. Anyone else?
Yeah, let me just mention what's very interesting in the commercialization of pharmaceuticals is 20% of all drugs are derived from plasma as a raw material. 90% of the plasma collected in the United States is collected by pharmaceutical companies, not the Red Cross or the American Association of Blood Banks. So out of all that, we've got this kind of individual product approach. There are 1.84 billion exosomes per ml in plasma. People pull out exosomes. There are 5,000 peptides in plasma. People pull out peptides. Johnny and I talk GDF11. Well, that's 1 out of 5,000. You've got 10,500 proteins, 45 cytokines, 50 sex-specific hormones. So what's interesting is it's all in balance in plasma, but you have these treatments of take a TPE and get IVIG. Those immunoglobulins came from plasma. Let's give them some hormones. Let's give them some peptides. All those are in the plasma. So rather than, build your car out of the parts department, go in the showroom floor, get the finished product that's put in balance, and then if you wish later, and we're talking 4 months later, fine tune yourself maybe with some peptides and things. But we often tell people, don't tune yourself up before you come in here, with human growth hormone and all these supplements, because you're getting it from the source. You're getting young plasma, which has it all, And peptides is a good example, literally 5,000 peptides in plasma. Let me put it another way. You get 3 liters, you get 5.6 trillion exosomes.
Here's a little something courtesy of my new best scientific advisor, ChatGPT. I just asked it, what are some of the components in plasma from young donors? And this is just some of the breakdowns. What kind of stem cells and progenitor cells? So these are just a few. EVs, exosomes. Well, here it gave this answer, which was a good answer, really. But cytokines, what are the names of some of them? Nutrients, metabolites, growth factors. I'll send this to you if anyone asks me. But that sort of touches on Tom's answer with just a few, not comprehensive specifics, but just a few.
So plasma remembers new, right? Stanford, everybody's been operating on the rats forever. So human trials, I shouldn't even say trials. There's no such thing as trial with plasma. I've been hanging plasma for 35 years. So human use of plasma for a therapeutic benefit other than pulling you back from death or a postpartum hemorrhage or whatever is pretty new. The biggest problem, like I said, with any kind of situation like this is the testing of what's going to tell you from a healthy level that you are getting better is really probably one of the biggest struggles. So what we started at, and this is all on our website, which is www.youngplasmastudy.com, because we did a Parkinson's study coming off of what Stanford did. Stanford looked at Alzheimer's, Parkinson's, in their study, turned around and there was some kind of politics, and then they turned it into that safety study, which to this day I still don't understand, because we've been using plasma safely on people with Parkinson's and Alzheimer's, when they get in car accidents for 100 years. So they really didn't give us any data. So we did our original study was done on people with Parkinson's. We took 20 people that had Parkinson's, 10 got plasma, 10 got B6. So it was double blinded, placebo controlled, it was IRB approved, and looked at basically the Parkinson's scale. And it was patients got a liter one day, a liter off, and then a liter the next day. We didn't make it complicated. We didn't do TPE. We didn't do any of that. We basically just gave them the plasma. And using the Unified Parkinson's scores done by a neurologist who had no idea who got what, the patients with Parkinson's got statistically better. So it was statistically significant. They got better. What was it? 6 months down the road, we did a 0, I think 1 month or 3 months and 6 months, 0.
Yeah,
months
136.
136. That's what I thought. So, and that paper is actually on our Young Plasma Study website, and I'm working on getting that published. Once we saw the benefit there and saw what was going on with sort of the other rat studies, our study that's going on now, the answer was to just create an observational study. We originally were an endpoint study, but now we're going to convert it to a big long-term, kind of a big observational study. So the Golden Gift study said you have 30 days to get between 2 and 3 liters. If you want to do a TPE, fine with it. If you want to just get straight plasma, fine. If you want to do a liter a week, fine. We just wanted a liter put in within a week, and then we were going to do a 4-month evaluation. And originally we were using the True Diagnostic epigenetic test until I found some really weird epigenetic kind of results that just didn't make any logical sense. One of them was in my dad. His heart failure got better, his BNP got better, all their markers, and we did cystostatin C and hemoglobin A1C. I did all these expensive markers on them just to follow them, because I figured I could do a paper on my mom and dad just as a case study. What I found is that his heart marker got significantly better, but his heart epigenetic marker got worse, like in 2 days. It just didn't make logical sense. It defied logic. And I talked to every PhD person I could think of. So what we're doing is basically taking a step back, still doing the liter we want to see where you are at 4 months, but we're opening it up to turn around and say, okay, what functional markers can we look at? I'm definitely going to use deep longevities. I'm going to use deep longevities blood marker, but we're also, like Johnny talked about, going to use more functional markers at this point. If you look at like your C-reactive protein, whether you look at it in blood or you look at it on the true diagnostic epigenetic test, it reacts. If you get a vaccine, if you it'll go up. If you do a C-reactive protein and then you get a little bit of a virus and then you test yourself, it's going to be elevated. Like those numbers are too variable to tell us what the plasma is doing. So we'll use the RDW. We're going to use grip strength. We're going to use balance. We're going to use VO2 max. So there's a whole bunch of functional markers we're going to add with the blood longevity marker. There's a mind longevity marker you can look at. We looked for a while at brain check. That's an online a brain test you can do to see if that gets better or worse. We tried to get them to come down on their price a little bit, and they were a little hardballing. So right now our study is really kind of open to functional markers and markers that change over that 4-month period of time. Go ahead.
And adding the WAVI brain
Oh, and the
scan.
WAVI, that's right. We're using that now. That's right. I forgot. That's right. So now the WAVI had a lot of our docs are using before and after, and that measures, I think, alpha beta waves, and it basically measures brain waves while you do a computer test. And it's like a 15-minute test. Because I've known the WAVI people for a long time. I was using it just with hormone replacement. You can see massive brain changes. I was using it in my office with women before and after hormone replacement. You could see a dramatic brain change 4 months into putting estrogen back in somebody's brain. So that's kind of where we are. And I think some of the reason that we turned it into that observational study is because it is a thing where you got to sort of throw mud at the wall and see what sticks a little bit now, and listen to everything and, pick up things that you start to see trends in. So that's what we're doing. Tom, you can tell them about kind of the specifics maybe of the collection, why it's therapeutic more than emergency.
Sure. And also what's pretty interesting, because the study is, as Diane mentioned, you can receive your 2 or 3 liters within 30 days straight IV, or you can do the exchange, do a plasma removal at the beginning, but don't use apheresis for the next 4 months because you don't want to pull out the young plasma. Or you can just pull out some blood, do a blood donation and throw it away, then get the plasma. Both of those pull out some of your old, but more importantly, they make space, as Diane mentioned, in your circulatory system. So that first day you can receive 2 liters straight up, because most people have an ability to take 1 liter. You don't want to get circulatory overload, especially when you're older. So, but we've also been watching this, and Johnny will have his study and everything else, but to date, the plasma is much stronger. We see uniform results between people who get IV and people who get exchanges. The method doesn't seem to really matter. It really is just getting the young plasma in. And what's pretty interesting, what's become very popular is people get a little vampire facelift, because the IV may take you a couple hours. So while you're on the recliner, get a little vampire facelift by pulling some of the young plasma out of the bag. I've done that. Diane has done that. And you can also pull some of the plasma out of the bag in a syringe. And if you have a bad knee or shoulder or wrist or something, give it a localized injection. So that's been pretty interesting. On the safety side, just very, very quickly, we've been using plasma 100 years. It was approved in 1938. There's an annual safety report. We do about 2.1 million transfusions a year. We use between 6,500 and 10,000 units of plasma every day. So tremendous track record on it. Standards are set by the FDA and the industry itself as far as testing. As Johnny mentioned, we perform a couple additional tests Just law of averages. One test is for what's called trolley, and it has a little antigen. Very rarely occurs, so the blood industry doesn't test for it. None of us want to be the one it occurs in, so we test for it. It's an expensive test. We test the donor's protein levels, which is not a blood bag standard because we're all in it for the proteins. So we do some extra testing. We also initially test for latent infections by requiring the donor to come in and give a pre-donation and then another donation. So they have to give multiple donations before their first donation is accepted, so there is no latency in anything. So we do all that, but it's a beautiful thing for these young people because we talk about apheresis. So I tell these college kids, start this early in your life, do it once a week, donate plasma once a week, and you may not turn out to become a diabetic, and you may not have neurodegeneration as you age, because in essence, we're paying you every single month to go through a plasma exchange. So you're keeping yourself healthy, because it's not the Count Dracula story, old people sucking the life out of young people. This is good for them to donate. Do it frequently. And secondly, we've got a place like in my forearm where I'd like to put that plasma. So it's a beautiful, it's really nice full circle, and that's a very nice thing.
Are there studies, Tom, on the longevity of regular plasma donors? I know there's studies on the lifespan of regular blood donors.
Well, yeah, and again, it's plasma because you're detoxifying with apheresis your plasma as you donate plasma. You can't do blood enough to have it be beneficial, even though if you're a European male, the blood loss helps, the red cells help. But the plasma, the irony is 90% of plasma at collection centers collected by pharmaceutical companies who the FDA allows them to pay people, so they prey on low economic communities. So they keep their mouth shut because the people are showing up just to get the money. And then you have the vaulted apheresis community in all these medical centers, the Dobry Kiprovs and the David Wards and all of those people performing the same procedure, and they don't even talk to each other. Even though we all buy the machines at the same place, Fresenius, Terumo, all the same machines, it's like worlds apart, and that's a huge disservice to the public because yes, there should be information about the therapeutic benefits of frequent donations, but the pharmaceutical company won't do it because they've got that money exemption, and the blood bank industry won't do it because they want you to donate your blood, not your plasma. So it remains unstated to the public.
I think the Red Cross also wants you to donate plasma. They have plasma drives. They sell it just like everybody else sells it.
I'm an associate of the Red Cross.
They don't collect plasma anymore?
Plasma is a byproduct because they centrifuge it in collecting the cells. They want the red cells and the platelets. All blood banks want red cells and platelets to support surgery. The plasma becomes a byproduct that they centrifuge out of it, and it's what's left over. So they don't purposely collect plasma, they purposely collect red blood products. And that's why there's only 10% of the plasma ever collected is collected by the Red Cross or AABB.
I think there's some confusion, Tom. I'm talking about a different procedure called double reds, where they give you back packed red cells after removing some of the plasma.
No,
they pay you for that procedure.
No, you're talking about the procedure. What I'm saying is they don't advocate using that procedure because it's contrary to their hospital contracts to provide platelets and red cells. So they have you donate blood and then they get plasma from it, but they don't want you to donate plasma and not get the red cells.
I think I understand. Thank you.
Yeah, there's always in the hospital, there's always a blood shortage. You never hear they can't get plasma. when you're walking around the hospital or wherever you are, the hospital's always sending us emails saying there's a red blood cell or a blood shortage. So that's why they want you to give them your blood.
And they pay for plasma, but not for blood
Well,
donation.
here's the big stupidity. So a little bit different. The FDA allows pharmaceutical companies to pay their donors cash. The FDA prohibits blood banks from paying their donors cash. 90% of the plasma gets collected by pharmaceutical companies. Blood banks always have a short supply. I wonder what the difference is. Maybe it's cash.
Yeah.
So it's just a not level playing field because the FDA wants plasma donors to go to pharmaceutical companies because that's 20% of the pharmaceutical industry and 75% of the FDA's budget comes from their investigations. So they keep that little circle going. Blood banks are in left field because they got their World War II, 1947 hospital contracts, and that's for reds and platelets. So they don't really engage that much in the pharmaceutical conversation. And since they can't accelerate their donations, you can only donate 6 times a year, they don't advocate the therapeutic use of plasma because they can't even keep up with their blood demands. So, although for the first time I did see the Red Cross 2 weeks ago offer cash for a donation, so we shall see. But that's how desperate they have gotten. But the disparity is clear. But for you yourself, again, and that's an answer to the question why there isn't stats on the health benefits of apheresis for frequent donors. But we know it's true, so you yourself are on the inside track.
I put a link in the
along
chat
those
for the
lines-
Red Cross site about plasma donation where they
David
So
Potter's had his hands up for a while.
Yeah, well, yeah, I know. Along those lines, I did my own independent research as to whether it might be harmful to, for example, college students or people in a young age group to donate plasma. And it showed that there are benefits to them, both in terms of health benefits, along with the financial reward, and college students can use some money, and along with just knowing that they benefited humanity. Also, there was a study by the Apheresis Society showing that long-term plasma donations over the years was not harmful. I think that's the gist of it. I'll send that. Send me an email. I'll send that to you. I think I got the last thing right. So there's that. And David, question?
Hey, this is a message for Tom. Let's say someone wanted to, this is a theoretical question. Let's say they wanted to save money and they just want to take some blood out of a relative and get their plasma and put it into themselves with no testing for any diseases, of course. What is like the mathematical rate of risks they're taking from getting some horrible disease from a relative that otherwise they think is healthy, but maybe has some latent infections? They just put it right into them.
Yeah, that's extremely ill-advisable. It depends on where you live. I mean, even in good communities, you can see trends. We're finding syphilis within some of these college kids. So I always thought my second business, Johnny, is to open up a college dating service because these are the good ones. But you can't tell. And so,
how often would the person end up regretting their decision? Like 10% of the time, 30% of the time?
I mean, I wouldn't even want to speculate because that's a unauthorized conduct. You do it on a battlefield or something, but you'd be out of your mind to do that. Now, the second thing is, which I told Brian Johnson, interesting difference between blood and plasma. is that you can get plasma from like ABO matched family members. And so you don't have the autoimmune problems you have with blood, you know, with the cells, as you know, with even getting a kidney donation or anything. Sometimes you're better off not with your family member, usually. Plasma, you can receive it within families. Of course, we're big on males get male plasma, females get female plasma. Whether you save money or not, I don't know. You know, it's your own family, so if they're not going down the Tijuana, maybe that's your choice to make. But
you still
safe
think
plasma comes
very
from
dangerous.
blood banks.
So very dangerous idea then.
Yeah, unconscionably dangerous, because even with the best of intentions, who knows? You know, again, so
Okay, thank you.
yeah.
Any other questions? Anything in chat that should be answered? Because I do have an answer now to Albert's question about the RDW. Ready to move on? Okay, we'll move on to that. I will show you my screen. This is a little write-up. If you go to the agingintervention.org website, there's a link to this somewhere. And then if you, these are the various therapies I've had for the last 2 or 3 years. But if you scroll down, you'll see this little write-up I did. So having said that, I will now show you my labs from the pre-test. Let's see, I had it on September 23rd, 2022. So the pre-test was the day before, 9/22. Let's find RDW. And that was 13.0. And for those of you who aren't RDW fans or don't know, lower is better. I believe that's red blood cell distribution width.
Well, thank you for showing us that. 13 is normal for your age range, I believe. But I want to comment that it's not completely monotonic. Very low levels are also unhealthy and associated with higher risk of death below 11.
Well, okay, great to know. But then the next one, 9/27. So this was like, what, 3 days after the TPE? And RDW was 12.5. Okay, not a tremendous drop, but I'll take it. And then finally, on 10/5, it was just a bit lower, 12.4.
Well, you got the trend in the right direction. That's great.
Yeah. Now let's take a look at my phenotypic age calculations. Here's the one on 9/20.
Nice.
And this is the thing that I kind of like. And albumin, good. RDW, this goes into the calculation to arrive at a phenotypic age. And my phenotypic age was about, what, 8.66 years younger than my chronological age. And usually it's like about 10 or 11. So anyway, you see that. If anyone wants me to send you this spreadsheet, I'll be glad to. Yeah, here's the one from 10/4. It went down to minus 12.22. So also, for those of you who want to calculate this, if you go to the Aging Metrics site, this is another one of my little babies here. It's loading. You can calculate your own phenotypic age. And well, while we're here, not to go on a different tangent, but I talked about I like the protein clock, and as opposed to DNA methylation as a measurement of biological age, it's closer to the end result, which it kind of sounds like Diane and I are on the same page. Function, how effective we are in our daily living, our vitality, our productivity, our joy of living are really the end results. But I think proteins are closer to the end result we seek. So I did, in one of my many past lives, I was in data analytics, software. I adapted a version of a protein clock and did my own little test. And those are the results. And kind of like others you've seen, the protein clock calculated age increases with biological age. That's the take home point. But getting back to this, if you click on calculate phenoage, you can enter the numbers here and calculate it yourself, or you can upload, and unfortunately this does not work with all LabCorp reports. They keep switching them up. But if you have a report from Life Extension, like their age research panel, I think it's called. I'll send, email me if you want the exact name and a link to where to get it. The price is like $77, and you can upload the PDF and it extracts the data and calculates it for you. So getting back to this, these are the things that Levine and Horvath, they validated these against DNA methylation age, but I found this is a handy calculation, and I'll send this to you if you want.
I think you have to remember, though, that this clock can have about, I think, a 3 to 4% variation.
Well, yeah, there's that as well.
Right. Horvath, Hannum, PhenoAge, that's the whole concept. And even there's a big argument about the pace of aging. But I'd be very careful.
Yep.
3 to 4% big variation in that, as far as, did I really get better?
Yeah, well, that's why with these, I prefer to do like triplicates, and hopefully you can average the 3. And the way I heard from 2 statisticians is that if there's one outlier, you average the 2, but still DNA methylation, it sounds like our experience parallels in that it's not necessary. It's a good indicator, but it's not necessarily always the best indicator of biological age. And I jump on that elliptical machine, and on the human benchmark, how many numbers can I remember? That's the 2 that I personally rely on most. And yeah.
Looks good, Johnny. I'll take a copy of that spreadsheet later. If you're
Okay.
there, yeah. Thanks.
Yeah. I'll send it to you. But the question was RDW, did it reduce? And it did, which is going in the right direction. Are we done with all this plasma stuff? Any more questions? Because I like to segment things. For those of you who don't know Vince Giuliano or who Vince is, he's a giant in the field. His blog, Anti-Aging Firewalls, is just a fountain of great information.
The last one is extremely interesting too. He came to, this is September 27th, was the last time he posted. And he came to some really interesting conclusions about aging. But again, unlike some of the great information I've heard today, he's not getting to the root. He's grabbing at certain things and coming to conclusions, which might be a step up. But what I heard today, which really excites the hell out of me, is we can really go another step up, a significant one, not the end step, of course, with this plasma exchange. So I have to really get serious about that.
Johnny, this has been great. Thank you so much.
Yeah, thank you. Was that Miles or?
No, it's Chris.
Oh, Chris, there you are. Oh, great. Yeah. Chris, hey, thanks for letting me muscle my way into your program yesterday. I really believe it was something they'd want to hear. So thank you.
Yeah, we're hoping to get that up on YouTube before too long. I mean, a lot of great people participated.
Yeah, yeah. Miles,
Johnny, you said something about cellular reprogramming. You mentioned it, but I could you maybe expand a little more? You said you were also involved with that.
oh yeah, yeah. Well, yeah, okay. I'll take it from square one. I recently moved to the free state of Florida here in the US. Miles, by the way, is a he travels to the US, and really again, thank you, Miles, for making these meetings happen. I'm just, chasing my tail so much these days on all the things I'm doing. Thank Miles for making these meetings happen, because he's the guy. But anyway, yeah, moved to Florida to be active in two initiatives which I believe have the greatest age management and reversal potential. The one is a Yamanaka OSK gene therapy initiative. I'm not leading this one, but I'm playing an active role in it and helping in several important ways. And basically, the intention of this therapy, when it's developed, is to reset the epigenome towards youth at just the sweet spot for us, not to a baby, but to age in our 20s or 30s or so. Also, as I understand, called cellular reprogramming. Now that one is a few years out. We have some world-class scientists working with us to develop the project plan. So that's one of the two. The other is my own plasma study, which I shared with you earlier.
Thanks very much. Thanks very much.
Yeah. Any other topics, or seems like we're winding down? Okay, going once, going twice. Okay, I guess I'll sign us off.